Your toe catches the edge of a hallway rug. Your hand finds the wall. Nothing breaks. You laugh, breathe, and keep walking. But pause. The question isn't only why you tripped, it's whether, if gravity had won, your hip or wrist would have held. That's the quiet power of osteoporosis screening. It moves bone health from the emergency room to a much earlier, calmer conversation. Not after the cast, not after the scary phone call, before the fall, when small choices still have room to work. On January 14, 2025, the USPSTF recommended screening women 65 and older for osteoporosis to help prevent fractures. That update matters because osteoporosis often gives no warning, no ache, no flashing symptom, just thinning architecture inside a bone that still looks normal. USPSTF reports osteoporosis affects 27.1% of women and 5.7% of men among adults 65 and older. After a hip fracture, USPSTF says only 40% to 60% of people recover their previous mobility and daily activity level. So screening isn't about calling anyone fragile, it's about seeing the structure before life tests it on a wet step. NIAMS describes central DXA of the hip and spine as the most reliable way to diagnose osteoporosis and predict fracture risk. NIAMS also calls DXA quick, painless, and non-invasive, which is why it can fit into ordinary preventive care. A DXA result estimates bone mineral density. Your clinician combines that with age, fracture history, medicines, family history, and other risks. The USPSTF recommendation targets adults without known osteoporosis or prior fragility fractures. It is preventive screening for people without symptoms. If you're a woman 65 or older, consider asking at your next visit whether a DXA scan is appropriate for you. The 2025 USPSTF update also recommends screening postmenopausal women younger than 65 when increased fracture risk is present. In plain English, menopause changes the math. Estrogen drops, bone breakdown can outpace rebuilding, and risk stops being just an age question. USPSTF points to risk factors like low body weight, parental hip fracture, smoking, excess alcohol, steroid medicines, and prior fractures. Bring the risk list, not a vague worry. Low body weight, a parent's hip fracture, smoking, heavy alcohol, steroid medicines, or a low trauma fracture. All matter. Low trauma means the kind of break that happens from standing height or less. A sidewalk stumble should not normally snap a healthy adult bone. For men, USPSTF concluded the evidence is insufficient to assess the balance of benefits and harms of osteoporosis screening. Insufficient evidence does not mean men are safe. It means the trial data are not strong enough for a broad screening rule. Still, USPSTF reports osteoporosis prevalence in men 65 and older, even though it is lower than in women. Men still break hips. Men still lose independence. The gap is not biology alone. It's what research has not answered yet. If you're male and worried, consider a personal risk conversation instead of waiting for a blanket guideline to catch up. NIAMS notes anyone can develop osteoporosis, though risk rises with age, family history, certain conditions, and some medications. Think of bones as living tissue, not chalk. They constantly remodel, taking minerals out and laying new material down. By midlife, the balance can tilt. Your body may remove bone faster than it replaces it, especially when hormones, nutrition, or medication shift. NIAMS says central DXA measures the hip and spine, the same areas where fractures can deeply affect mobility and independence. If you schedule a DXA, ask what body sites will be measured, how results affect your fracture risk, and when repeat testing makes sense. The scan is not the finish line. It's a map. A low score points to choices your clinician can tailor. USPSTF says women found to have osteoporosis should be evaluated, counseled, and, when appropriate, offered evidence-based management. That word, management, is doing a lot. It can include food, movement, medication, vision checks, footwear, and the floor under your feet. Nutrition is part of the plan, but it's not just Take calcium and move on. Consider food patterns your doctor or dietitian can personalize. NIAMS lists calcium and vitamin D as bone health nutrients, while also emphasizing exercise, medicines when appropriate, and fall prevention. For calcium, consider yogurt, fortified soy milk, canned salmon with bones, tofu set with calcium, collard greens, or a tailored supplement if advised. For vitamin D, sunlight helps some people, but blood levels vary. Ask your clinician whether testing or supplementation makes sense for your situation. Then comes resistance training, the piece bone health conversations often skip. Muscles tug on bone. That mechanical signal may help maintain strength. One approach is 2 or 3 weekly sessions. Sit to stands, wall push-ups, rows with bands, loaded carries, or supervised weight machines. Start where your joints feel safe. If balance is shaky or you already had a fracture, consider a physical therapist before adding load. NIAMS recommends weight-bearing and muscle-strengthening exercise as part of osteoporosis care, alongside nutrition, medicines when needed, and preventing falls. Weight-bearing does not have to mean jumping. Brisk walking, stair climbing, dancing, and hiking. Ask your skeleton to work against gravity. Balance training deserves its own slot. Consider heel-to-toe walks, single-leg stands near a counter, tai chi, or supervised balance classes. Falls are not moral failures. They're physics meeting bad lighting, sleepy medication timing, loose rugs, and shoes that slide on polished floors. Walk your home like a detective. Consider removing loose throw rugs, adding night lighting, clearing cords, and keeping frequently used items within easy reach. If your vision has changed, consider an eye exam. If you feel dizzy, ask whether blood pressure or medication side effects could contribute. NIAMS includes fall prevention and osteoporosis steps because reducing falls may lower the chance that weakened bone faces a high-force test. This is where prevention becomes layered. Stronger bone helps. Stronger legs help. Safer rooms help. Better medication timing may help. The USPSTF finds a moderate net benefit for screening women in the recommended groups when osteoporosis is followed by appropriate care. Notice the phrase, followed by appropriate care. A scan alone doesn't strengthen anything. It opens the door to the right next step. If medication comes up, ask what fracture risk it targets, how long treatment usually lasts, and what side effects are worth watching. NIAMS describes osteoporosis medicines that slow bone loss or help build bone. The right choice depends on fracture risk and health history. Medication is not a character judgment. It's one tool for a specific risk profile, especially when fracture odds are high. If you've already broken a bone from a minor fall, consider asking whether that event should trigger osteoporosis evaluation, not just orthopedic follow-up. The USPSTF screening recommendation does not apply to people with known osteoporosis or fragility fractures. Those situations require clinical care. That difference matters. Screening is for finding quiet risk. A low trauma fracture is the body speaking loudly. Before your appointment, write 3 things. Any adult fractures, medicines like steroids or hormone blockers, and whether a parent broke a hip. Also note recent near falls. A caught toe on a rug counts as useful information, even when nothing dramatic happened. Near falls are prevention gold. They show where your environment almost failed before bone, muscle, and reflexes had to pay the price. Consider inviting a loved one to check your stair edges, bathroom floor, pet pathways, and outdoor steps with fresh eyes. USPSTF highlights hip fractures as especially serious, with many people not returning to their previous mobility or daily activity level. That statistic is not there to scare you. Breath, it's there to show why earlier conversations are kinder than late ones. If this episode is useful, consider liking or subscribing. It helps more people hear evidence-based prevention before a crisis forces the lesson. Let's make it practical. At 65, ask about DXA. Before 65, after menopause, ask whether your risk factors change the timing. If you're male, ask a risk-based question. Given my history, medications, weight, smoking, alcohol, or fracture history, should we evaluate bone density? Pair that with a movement plan you can repeat. Strength twice weekly. balance practice most days, and walking or stairs as tolerated. Pair meals with bone-building basics, protein, calcium-rich foods, vitamin D guidance, and enough total calories to avoid unintentional weight loss. And if your clinician recommends medication, consider it part of a prevention stack, not a failure of lifestyle. The rug at the beginning is still there. Maybe you tape it down. Maybe you move it. Maybe you buy shoes with better grip. Softly, but the deeper shift is this. Bone health is not a lecture after something breaks. It's a conversation before. The 2025 update gives that conversation a doorway. Walk through it with questions, not fear, and let prevention be ordinary. Your bones are not frozen in time. They respond to load, nutrients, hormones, medicines, and safer surroundings, sometimes slowly but meaningfully. This content is for informational purposes only and is not a substitute for professional medical advice. Always consult your doctor or a qualified healthcare provider before making changes to your health routine. For today, notice the rug, the stare, the skipped strength session, the unanswered screening question. Prevention often begins with noticing.